So I have no conflicts to report, and a thank you to Dr. David D'Souza, who's taught me nearly everything I know about this topic. This is Fluffy the cat. That is my 10-year-old's cat. I never thought I would have a cat named Fluffy, but here he is. So here are the educational objectives today. Even though that I will be touching upon a number of topics about a number of areas, a number of conditions that can cause impairment, I'll be mostly focusing on the process of evaluating the impaired employee, the initial impairment evaluation. And you can see the second objective here, if there's any pitfalls or obstacles that can be avoided. So first, I'll be talking about what is impairment, what is safety-sensitive work, how does the employee come to our attention at our department, what to do with the employee once they're in our office, making a determination of fitness for duty, the follow-up visits before the employees return back to work, the return to work process, and lastly, I'll just be touching a little bit about long-term follow-up. This is a process that cannot be just distilled into a simple cookie cutter recipe and needs individualization just like any other medical visit. However, these particular visits are concentrated on the safety of the employee and the patients and coworkers that they come in contact with. So impairment is the inability to perform the essential functions of work safely and effectively, and is a result of a new or decompensated medical, psychiatric condition, use of medications, inappropriate use of substances, and any other potential medical cause. The impairment evaluation focuses on determining what is the medical reasons for the impairment, how severe it might be. Can the employee be returned back to work right away, or do they require further treatment and further evaluation with their treating provider before they return back to work? And lastly, when the employee may be returned to work safely. So I've been doing this since 2001, and I wondered if there was anything in the literature about this particular process, and I did find this article by Fan, and you can see the steps that he takes here. And this is his article concentrates on not just healthcare workers, but various other industries outside of healthcare. So here are the steps that he takes. Identify the potential risks, which he calls orbit of harm. What are the mental and physical demands on the employee? And the actual medical evaluation, the different factors that go into that particular exam. And after that visit, making a determination if that worker can return back to work safely based on what their job responsibilities are. And if they can go back to work, do they require any limitations or restrictions? So we use much of the same type of process here in employee health. And first, the employee comes to our attention usually from a phone call or an email from a manager. And the manager and or coworkers may have observed a number of concerning behaviors. And here they are. This is not an inclusive list. And most of these behaviors are observed at the workplace, but occasionally outside the workplace. When I speak with the manager, I get an idea about what the work performance issues are. I try to get a timeline of the events, and I ask specifically about what type of mistakes are made, how serious they might be, including any close calls. After speaking with the manager, I'll ask them to write this information up in email and send it to me. Now, if you're having this conversation with the manager and your office is closed, or you can't get the employee right to your office immediately, you do need to think, should that employee be pulled right from duty? Or is there a concern about their medical or psychiatric stability, and do they need to be referred right to the emergency department? I do document the conversation with the manager in the EMR, and I alert the employee health staff about the evaluation. One thing that we strongly discourage employee health staff from doing is taking this email and any other emails and cutting and pasting it and putting in the EMR. Really, we tell them, make a summary, don't cut and paste emails into your EMR. So ideally, you want to see the employee as soon as possible. This has a number of important reasons for it. First of all, a more timely examination of the employee allows you to corroborate what is being reported by the manager and the coworkers. Also, if there is a concern about substances, time can be quite critical, as you know, with breath alcohol testing. Some substances are very short acting, such as the metabolite of heroin, fentanyl and propofol, very short half-lives. Cocaine's only about a day or so. Most other substances remain in the urine 3 to 5 days after use, but ideally you want to try to see the employee as soon as possible. If your office isn't open, as I mentioned, you may need to refer them for emergent care. And if it is not practical to do a drug test right away in your office, sometimes we've partnered with the ED and have them do the substance abuse testing. So the breath alcohol and the drug testing, this needs to be a forensic test and not the medical test. So when the employee arrives to the office, they're usually quite upset. They're usually quite nervous. So I try to put them at ease. I'll introduce myself and I'll ask them, do you know why you were sent in? Sometimes they know, sometimes they don't know. I do reassure them that the purpose of the visit is to determine their medical fitness to return to duty the same way we would do with an airline pilot. So in this way, they feel less singled out. I also explain to them that if any employee is referred to our office for an impairment evaluation or safety evaluation, I have to follow certain standard practice, and there are certain things that I have to do before they can go back to work. I answer any questions at this point. I've had a few employees who insist on having a witness, not that many, but if they do, you have to get a witness from your own staff and document the names in the medical record. Having a labor or legal representative present during the exam is inappropriate, as this is a medical determination. So with the history of present illness, you can take different approaches with this. My approach is that I'll ask them about each one of the work performance issues, and I'll document what they say. I'll look out for if they are being straightforward with me, if they are evasive, if they seem to be minimizing symptoms. I do need to probe further. This is a safety evaluation, and you really need to determine if it is safe for this employee to go back to work. This can sometimes get a little uncomfortable, but you really are there to first protect the patients that they care for, and it's also to help the employee. I don't take the line that this is a police interrogation. That's not a good idea. And as I'm taking their history, I form a differential as far as the cause of the impairment or impairments. The past medical history, if I haven't already covered it in the HPI, I'll ask about their medical problems, and being alert for any kind of safety concerns that may come up. So is there anything in this area of their history which could be contributing to their presentation to my office? Are there medications? Are they actually following the treatments of their doctors? Are they following through? Have there been any changes in their treatment or prognosis? Is the disease or one of the diseases in the past medical history actually progressing? And also side effects from any medications or treatments, which could affect them and their performance on their job. Past surgical history, occasionally in some of the impairment evaluations, this does apply. You tailor this portion of the history as you would with any other portion of your history with the HPI. I will make a note here that I don't think it's used that much anymore, if at all, but cocaine in the past was used as a topical anesthetic in ear, nose, and throat procedures, dental procedures, and occasionally in the ED, and could explain a positive cocaine on the urine tox. Psychiatric history. If assuming that you didn't already ask a lot of these questions based on your differential, but these are the elements of a psychiatric history. Are they stable cognitively and emotionally? Are they safe to have any direct patient contact? You should ask these questions as you take their history. Do they have any concerning symptoms, such as are they delusional? Are they psychotic? Are they having cognitive impairment? I do ask directly about suicidal ideation, and even if they are not actively suicidal at the time, you do need to ask some of these other questions, which may increase or decrease the risk of suicide. I do ask about homicidal ideation, side effect of any medications that they may be prescribed, and are they actually adhering to the treatments that they are being given by their treating providers. Medications. Medications can be a significant contributor to impairment, especially if it's a controlled substance. If they do say that they have a controlled substance, I'll ask them, who prescribed it to you? Does your worker have a doctor-patient relationship with the prescriber? Occasionally, we've had a few residents who've been prescribed substances by a co-resident or a friend or a family member. This can be problematic. Use of over-the-counter medications, herbal supplements and vitamins sometimes interact with prescribed medications. Use of CBD, and if they are on a controlled substance, are there any concerns about addiction? Are these treatments appropriate for their medical conditions? Part of the history is asking about substance abuse, current and past. What are they using? How much and how often? When was the last time they used? Any past history of substance abuse. So they may say, I'm not using any drugs at all. If you suspect it, you may need to probe to see if they previously used it, which would increase their risk of current use and possible relapse. I do have this diagram from this article here about cannabis. As you know, the metabolism and effects on patients can be quite complicated, and there's a number of factors that can modify the end effect. So you can see that this is quite complicated. All these other factors can go into the end effect on the employee if they are using cannabis. Alcohol use. From what I've read, there is no safe amount of alcohol. However, there are at-risk uses, and you can see the population groups here. This is females and males 65 years and over. You can see the quantities here. And the recommended limits for this other population group for males under 65. So, I ask about the quantity, how much, how frequently, what they're drinking. If you are evaluating providers, doctors, nurses, they may know what answers you are looking for and may not answer the cage questions accurately. It's helpful to get supplementary information. So history of fights, injuries, arrests, legal financial problems, new onset medical problems such as high blood pressure. Let's just say you have a 28-year-old who has high blood pressure. Maybe it's alcohol, insomnia, mood disorders, abnormalities in the lab. So if you have that resident that you saw 2 months ago for a BDFE and the LFTs were elevated and they said, I don't know what it is from, this may give you some additional evidence that they may have a problem with alcohol. And as you take the history, does everything make sense? Are there inconsistencies? Is the employee being forthright with you? Are they denying or minimizing the problems? You may need to ask some additional questions, and you do need to speak with the treating provider to corroborate anything. So your physical exam will reflect your differential of your history. So if you are suspecting more substance abuse, you'll you'll gear your physical exam to looking for signs of substance abuse. If it's a medical condition such as decompensated cirrhosis, you'll do that. I do, sometimes you don't need to do a full comprehensive head to toe exam, but if you are being more comprehensive, if you are looking at areas that might be considered more delicate, you might want to consider a chaperone. This evaluation can be a little adversarial, so you do need to proceed mindfully. Your psychiatric examination, especially if your differential has placed a psychiatric medical condition high on the list. These are the basic elements of a psychiatric exam, so they should be in it. I'm not going to read out all these different elements. Your cognitive exam. So if you have an employee who is being forgetful, doesn't seem to be following directions, the MOCA test is the test that I use. I know that other providers do the mini mental status exam. These do have limitations, and I will speak about these later. But for high functioning individuals who scored poorly on the MOCA test, so if you have an 80-year-old physician who scored 20 out of 30, sometimes seeing that on the MOCA test, things will click for them and they'll stop pushing back on you and saying everything is fine. They'll realize not everything is fine. They need to get evaluated. And of course, as I mentioned, suicidal, homicidal ideation, if they are outright psychotic, you probably need to refer them immediately to psychiatry. So who needs urine tox? Most employees will get a urine tox. Not everybody does. You have to use your medical judgment who gets a urine tox and who doesn't. It shouldn't be an automatic process, but certainly there are employees whom you should have a lower threshold. So an employee who has given you inconsistencies in the history that they cannot explain, they seem to minimize or deny answering questions, they seem to be evasive. If they have any of the red flags in the history, which I've detailed in this second bullet point here, yeah, you need to do the urine tox. And as far as the panel that you select, make sure that it's broad enough. If that employee has access to a broader number of drugs, such as those in anesthesia, those in ED, you may need a larger panel. And there are certain substances that aren't on the standard panels that you may need to add on. I'll talk about this a little bit more. And what happens if the employee refuses drug testing? Here I'll lump in a few things. So if the employee refuses the history, refuses the exam, refuses to let you speak with their doctors, it refuses with any portion, I try to find out why, and I try to persuade them that it's at their best interest to really let us, proceed. This is our process. We have to follow the process. If they are refusing, let them know that it's only going to delay their return to work. And I will notify HR and their manager if they are not cooperating. But try to persuade them to cooperate with you. I've had a few employees who demand to see the policy. You can refer them to policy tech. An employee who threatens legal action, notify your risk management department in HR. This usually doesn't come up during the initial visit. It's sometimes afterwards, especially if you're not going to return them back to work when they want to return back to work. With or without a threat of legal action, I make sure that I document thoroughly. I keep all the emails. If they threaten you verbally or physically, try to de-escalate if possible. Certainly, if you feel something not right in your gut, excuse yourself in the room. I had a psychiatry professor in medical school who strongly advised that if you feel the hairs on the back of your neck starting to stick up, regardless of what the content of the conversation was, get out of the room, listen to your gut, they're probably going to become violent. It is a good practice not to have the evaluated employee between you and the door if you need to get out of that room quickly. And some offices have silent alarms installed in the desk. So this I've covered already. And at the close of the visit with the employee, I'll give them a brief summary, and I'll tell them what they need to do to return back to work. And I'll answer any questions that they have. For most of these evaluations, I do need to speak with the treating provider, so I'll have them sign those medical consents while they're in the office. If they admitted to substance abuse, I'll refer them right away for either professional assistance program, and there is CPH for doctors and SPAN for nurses. Many unions provide services as well. Also, you can refer employees not just for substance abuse, but mental health issues to EAP and the Center for Stress Resilience and Growth. If you did have some type of safety concern, but it wasn't so high that you referred them to the emergency department, it's good practice to call them a day or so to make sure that they're still safe and make sure that they're still stable. I do remind employees, especially if they're going to be out for the 5 days or more, that they do need to apply for medical leave or intermittent leave. Most employees are taken off duty. Not everybody does. Once again, you have to use your medical judgment. Certainly, if there are any pending tests, alcohol or drug testing, you should take them off duty. You do not want to have a nasty surprise. I do notify the manager or HR about the disposition of the employee, whether they will return back to work or not, and when their follow-up visit is. Some managers want to have an idea about how long the employee might be out because they have to drop a schedule. So I'll give them my best guess. If your alcohol test is negative, you might need to reconsider your differential. Certainly, if it is dilute negative, you may need to repeat it, possibly with direct observed. It depends on the circumstances, it depends on how high your suspicion is, and also you may need to look at the substances that you tested in your urine panel. Is it broad enough? Some substances, such as GHB and MDMA, are not always routinely contained in the standard panels. And do make sure that you follow up your urine testing. Samples do get lost. Sometimes you don't get an alert from whatever testing center you do, and they're just waiting for information for you. Maybe you forgot to check off a box when the urine was collected, and you don't want it sitting there for 2 weeks, kind of wondering what happened, and you just simply forgot to check off a box. So if I've taken the employee off duty, I will have them follow up with me in the intervening time between the initial evaluation and the return to work. It is important that they are following through with the evaluation with the treating provider if they are getting substance abuse treatment, making sure that they're all going according to plan. And I'll call providers usually shortly after the initial visit. It's very important for providers to be aware why the employee was referred to the employee health service. Not all providers are even aware of what their patients do, or that they even do safety sensitive duties, or that they were even decompensating as much. For some circumstances, it's even helpful to have a job description. This is usually more applicable on returning the employee back to work, especially if they're being returned back to work with some limitations. I discuss with the doctor about the medical problems, medications, and maybe making an alteration to any of these treatments so that the employee is not impaired further when they're returned back to work. So As they get closer to return to work, I make sure that the different issues are getting better. So if they were out for uncontrolled diabetes, glucose is more stable, anemia is being treated. Um, I've mentioned some of these issues before. Sometimes you have to make multiple calls to providers, and this really depends on what the employee was out in the first place. You want to make sure that all these issues are addressed before the employees return back to work. If you don't, they'll probably be sent back to your office within a few days or weeks after you return them back to work. And keep in mind that any new medications or old medications must be compatible with safety-sensitive job duties. If the employee was out for psychiatric issues, these are the questions I ask myself and ask the treating provider. It's especially important to know what the diagnosis and treatment is if you're not already aware of it. Is the employee following through and seeing a therapist and psychiatrist? How often are they being seen? Some psychiatric providers really will not write a note saying that their patient can go back to work. They don't feel comfortable with that. So I'll compromise with them, and they are usually more willing to write something along the lines, my patient is psychiatrically stable, or the depression is markedly improved. In some mental health conditions, the provider will want to ease their patient back to work, so part-time limited patient load, limited hours, and then this is gradually increased over time. You'll need to do follow-up assessments of these particular employees, as you would with any other employees return back to work with limitations or restrictions. Cognitive impairment in employees, it becomes more of an issue in the licensed professionals. Certainly, from this article by Swift, shows that formal neuropsych testing is really required in this population of higher functioning individuals because the screening test, the MoCA and mini mental status test, may be relatively insensitive. Some, especially doctors and some nurses and nurse practitioners, may be used to doing these tests themselves, so they know what the answers are. They know. So if you have that doctor who scores a 28 on the MoCA test, it may be because they know the test, and also they have a relatively high functioning cognition in the first place that has decreased, and their 28 is really the equivalent of a 20 out of 30 in most of the other populations. So you'll need to do a neuropsych testing. The neuropsych will actually outline the limitations, where are the limitations, where are the deficits. And first of all, I review the neuropsych report myself. I speak with the examiner of the neuropsych exam and discuss their findings and also what their patient does. So for the most part, they will ask, oh, gee, this is a doctor, this is a nurse, this is an executive. I'll ask them if their opinion is permanent or temporary. That might be more of the area that I'll ask the neurologist. What are the impairments? What are the restrictions on the employee? And sometimes it ends up, especially if it's more permanent, possibly no direct patient care. Substance abuse is a process in itself to make sure that the employee is going through the whole treatment process and is stable enough to safely return back to work with a low probability of relapse. So I'll speak with the counselor and make sure that they agree. I won't just accept the documentation. You can get a note from the treatment program that they can go back to work. I'd like to speak with the counselor as well to make sure that they're on board and that they are aware that they are treating a healthcare provider. And also, if you referred your employee to a professional assistance program, this program may have some recommendations about limitations on practice, such as no nights, no work with opioids or controlled substances. We have had a few employees who do go back to work, and they are on opioids. This can be quite problematic, and you have to take an interactive process with this. So there are some questions you need to ask, especially if the treating provider is insistent that their patient needs to be on these medications, especially if it's scheduled. According to this New England Journal of Medicine article from 2019, really you shouldn't be prescribing opioids for any chronic pain. It has a number of significant adverse effects, and especially this one, increased motor vehicle accidents. You can translate that to increased serious accidents at work, sedation, and also just their functional improvement. So if they're on opioids for back pain, that can impair their ability to go back to full function. And the CDC released this statement in 2022 about safety sensitive work and opioids. Really, they're recommending against it. If your employee is on a controlled substance or potentially sedating substance, that is more PRN. I do advise the employee not to use within 8 to 12 hours of a shift or driving. I'll document that I've told them this. Cannabis use, as you know, it is legalized, both recreational and medical, and the safe amount of time between use and working is about 48 hours. I've had a few treating providers who say, my patient's perfectly fine. And you've evaluated the employee again for a follow-up visit, and you know that they're not fine. They should not be around heavy machinery. They should not be climbing up on heights. Maybe they shouldn't be seeing patients or operating. So in this case, I'll speak with the provider. I'll try to find out the reason for why they are insistent. Now, if they still are insistent, ask them to put it in writing that they believe, despite this medical condition, their patient can perform safety sensitive work. Most of the time, they're not willing to put their license at risk. And you are still, I'll just emphasize this here, that as the employee health provider, you are the one primarily responsible making the determination of fitness for return to work. Provider won't change medications or treatments. This is an interactive process as well. So I speak with the provider. If I'm still not getting anywhere with the treating provider, they won't change the treatment, and the employee really wants to go back to work, you might have to consider an IME or even returning the employee back to work with restrictions. So on this last slide here, the long-term follow-up, I'll just touch upon just very briefly because it depends on what the impairing medical conditions were of the employee. So certainly if it was substance abuse, random testing does act as a deterrent for relapse. Alcohol use has a high relapse rate. So, breath alcohol is generally detecting it within hours. ETG is anywhere from 2 to 10 days, and it's to monitor for compliance. The breath alcohol test will only show use within a few hours, so it's not so sensitive. And sometimes we've had a few employees who time their alcohol consumption when they could be tested for the urine. So for some of these, we've had to do a serum PEth test, and I have the article here and recommends interpretation of this particular test, but the PEth test can potentially detect alcohol use up to 28 days. And cognitive impairment and other degenerative diseases may need more long-term follow-up than the usual 3 to 6 months that I'll follow most employees, as these could progress. And sometimes I have to take the employees back out of work. Sometimes I have to alter their restrictions. And thank you.